Thank you, Carrie. Welcome to the webinar. I'm Dr. Teresa Humphreys-Wadsworth. I'm an Associate Project Director with the National Action Alliance for Suicide Prevention. And the Action Alliance is proud to present today's webinar. The Action Alliance is the nation's public-private partnership. It is a nonpartisan, independent partnership focused on implementing and coordinating strategies to advance the national strategy for suicide prevention. Within the Alliance, one of our components that we're focused on is transforming health systems. And last November, we released the Care Transitions Best Practices Report titled Care Transitions for Individuals with Suicide Risk, Inpatient Care to Outpatient Care. And today's webinar will highlight the role of connectedness in care transitions. Now I'd like to introduce our panelists and speakers today. Dr. Richard McKeon, Chief of the Suicide Prevention Branch at the Center for Mental Health Services of the Substance Abuse and Mental Health Services Administration, or SAMHSA. Karen Johnson, Senior Vice President, Clinical Services and Division Compliance Officer in the Behavioral Health Division at Universal Health Services. Becky Stoll, Vice President of Crisis and Disaster Management at Centerstone Health. And Shelby Rowe, Program Manager for the Oklahoma Department of Mental Health and Substance Use Services. Thank you to all of our presenters, and now I'll turn it over to Dr. McKeon.
Thank you so much. I'm going to start by talking a little bit about the scope of the problem, which of course is familiar to many of you. You can move on to the next slide. And we know, of course, that suicide in the United States tragically has been increasing over a period of many years, with over 48,000 suicides in 2018, the last year for which we have complete data. We know that suicide has been increasing in 49 of the 50 states. Unfortunately, we don't know what the impact of COVID and the current pandemic and everything associated with it is going to have on deaths by suicide. But it's also important to recognize that deaths by suicide, as tragic as each and every one of those is also only in many ways the tip of a larger iceberg of the impact of suicidal ideation and suicide attempts. And so, as you can see on this slide, we know that there are over 400,000 hospitalized overnight or longer for a suicide attempt. Of course, that doesn't even account for those who are hospitalized because of suicidal ideation. We know that over 700,000 received medical attention for a suicide attempt. And we know that there are, from the National Survey on Drug Use and Health, over 1.4 million suicide attempts annually just among adults, not even counting those under the age of 18. So there is a very significant scope to be taken into account. And we obviously need a comprehensive approach to make the kind of decreases in those numbers that we all want to see. But the issue of care transitions is one really important place where there's excellent evidence that we can make a difference. Move to the next slide. So the transition from inpatient care to outpatient care is of particular importance for us to pay attention to. We know that all kinds of transitions are important. Transitions after leaving emergency rooms. There's 2 recent studies showing heightened elevation of death by suicide in the 12 months after emergency room discharge. But today we're going to be focusing on the transition from inpatient care to outpatient care. A study published last year by Chung showed that the rate of death by suicide is 300 times higher in the first week and 200 times higher in the first month than in the general population. So highly elevated. About a decade ago, the VA published a study of about 1 million veterans treated for depression. And the time of greatest risk for those veterans who were treated for depression in terms of for suicide was in the time after inpatient discharge. So it is clear, and there are international studies that document this as well, that the time after inpatient discharge is a time of heightened risk. And that risk is particularly high in the first 30 days and particularly in the first week. And although heightened risk continues afterwards, that there's clearly that high risk period of the first week and in fact the first 30 days. That's compounded by the fact that a third of patients do not complete a single outpatient visit in the first 30 days after an inpatient behavioral health care discharge. So even though it's a time of heightened risk, many people do not get any kind of follow-up care, underscoring the importance of our being able to do better in reaching out and assisting people at this very vulnerable stage. There is also information from Brian Amadati and the folks at Henry Ford and the Mental Health Research Network that 1 out of 7 people who died by suicide had contact with inpatient mental health services in the year before they died. So the fragmentation that's typical in care has a tragic cost that we need to pay attention to. By paying attention to it, I think this is one of the areas that we can, where there is the greatest promise for saving the greatest number of lives, for something that is doable. And I should also mention there are multiple studies that show that intervention during this time period can be life-saving, can reduce suicide attempts. Okay, you go on to the next slide. So it's important that these care transitions, that they are seamless and that they work to the patient or the consumer's benefit rather than just having a number to call and having to negotiate a system on their own. So it's really important for us all to work as a collaborative team and to work with the recently discharged person in a collaborative manner to try to help keep them safe and link them to care. Probably the most important element of being in contact with someone, like making a call after 24 or 48 hours, is the human connection, that somebody cares, somebody cared enough to reach out, and that once they stepped out of the inpatient unit, that there was still concern for them. There are other tasks that we want to be involved. There's a need for some ongoing risk assessment, for trying to assist the person in problem solving and getting them connected to care if there are obstacles, and to build the bridges between our systems. Unfortunately, in many places, our services are fragmented. Some places have built coordinated systems and they've built bridges between one service and the next, but in a lot of places that doesn't exist. So seamless care transitions are about collaboration, connection, and building bridges, working as a team. So you can move on to the next slide, and I'm going to be turning it back over to Teresa.
Thank you, Dr. McKeon. Our next presenter is Karen Johnson, Senior Vice President and Clinical Service and Division Compliance Officer at Behavioral Health Division of Universal Health Services. Karen, I'll turn it over to you.
Thank you, Teresa and Richard. Good afternoon. It is my privilege to discuss the key principles and recommendations from the best practices document as it pertains to inpatient providers. UHS manages more than 135 inpatient psychiatric programs throughout the U.S., and to know of the statistics that Richard shared compels all of us to strengthen the process of transition. It is vitally important to save lives. Immediately upon admission to an inpatient facility, discharge planning should be contemplated. As a social worker myself, it was one of the very first things I learned about inpatient care. And everybody understands the significance of that starting upon admission. What level of care will the individual require is the first key question. Assisting the individual and the family in understanding that the care that is being provided in the hospital is just the first step in recovery. Building upon the individual's needs and available resources will occur through the hospital stay. But the critical component that occurs early on is identifying those resources. Does the individual have a treatment team outside of the hospital? Or do we, as hospital providers, need to establish that team? Collaborating with the external treatment team begins immediately as well, if one exists. It's important to understand what treatment goals the existing treatment team has, and how and when the existing treatment team would like to assist in preparing the patient for a swift and smooth transition to outpatient. Most facilities have their own approved network, and I say that in air quotes, outside of those that are approved potentially by the individual's payer. The connection to that network is strengthened by establishing a memorandum of understanding or an agreement with that individual provider. What does that look like? It focuses on the critical components of sharing of medical records, transition plans, crisis safety plans, medication lists, other assessments. And the partnerships and the communication are key to that successful transition. Delivering that material electronically is also key so that the outpatient clinician and or team of clinicians has the information at the time that the patient arrives for their first appointment. The key to success in any hospital stay, let alone a psychiatric hospital stay, is the involvement of family members and other natural supports. In our work, we have a very broad definition of what support means. If the individual patient indicates that another individual is a support to them, that's good enough for us. But there are also times that that support network may also need support. So while it's critical that we remain focused on the individual in care with us, their support team may also require support of their own. The use of peer specialists and outside support groups, along with education around signs and symptoms of relapse, in the broadest definition of the word relapse and suicide risk, are critical components of this recommendation. For children and teens, we can't forget the notion of utilizing schools as that support, although, as we all know, very difficult in the age of COVID. Teachers and counselors are still a critical component of community support for young people. Development of a safety plan is also something that begins upon admission and evolves throughout the course of care. Safety planning is a key component of the overall training that the UHS nursing and clinical staff receive as part of their onboarding to our facilities. It is part of their orientation program, and it's also part of their annual training in order to fulfill the responsibilities of their employment. This is another opportunity to collaborate with the individual in care and their support network. During a hospital stay, coping strategies are developed and worked with and individualized to the needs of the individual patient. At the time of discharge, these are reviewed with all parties so that the plans can be managed away from the hospital. A crucial component of the safety plan is a plan to reduce access to lethal means. At UHS, we ask this question at the time of admission. We obtain and document the name of the individual who is going to secure any lethal means, and we use the broadest definition of that we can, including medications and the medications that the patient is discharged with after they leave our care. We typically will only supply a 15-day prescription with refills. This does become a challenge with certain payers, and as such, we make adjustments. But our first concern is always of the safe use of medications that are required to stabilize and provide care for the patient. Also, we want the individual to have the first appointment with their psychiatric provider, ideally before the prescription runs out. As we all know, readmissions and relapse are often tied to an inability to obtain medications. The next component of the transition is the connection with the outpatient provider. It is a best practice standard of care in the industry to schedule an outpatient appointment prior to discharge. When at all possible, utilizing step-down care is critical, meaning offering an intermediate level of care such as partial hospitalization and intensive outpatient services prior to a traditional outpatient appointment. In the age of COVID, UHS, along with many other providers, have established a robust telehealth platform to connect individuals to treatment when going to a bricks-and-mortar treatment location provides more anxiety than support. Quite frankly, this has improved our compliance with step-down recommendations by greater than 50%, 15. We were quite pleased with that, as it demonstrated to us the importance of that connection between the individual in care and their external treatment team. Since it couldn't happen in person, we had to figure out a solution to support our patients in this time. When we own the system of care, meaning that the partial hospitalization or intensive outpatient is part of the UHS facilities, our therapists meet with the potential patient prior to discharge and can even invite the patient to join a group or two to assist in the transition. When we do not own the system of care, our therapists, along with the patient, make that initial contact so that we can connect that patient to the therapist to ease the transition. After discharge, following up with the patient and the outpatient provider is key. The sharing of medical records, including the safety plan and medication lists, are required documents, not only by UHS, but by our regulators. In fact, we are measured on the accuracy of the continuing care documents from both the Joint Commission and CMS. In addition, follow-up calls and caring contacts are critical. Leaving a hospital is a very risky time, as we all know, and certainly after Richard shared those statistics, the risk for suicide increases. Providing hope with caring contacts is critical. Letting individuals know that we as healthcare providers care for them even after they leave us is critical. Finally, I will close with some more specific practices that UHS employs to prepare for each individual transitioning to outpatient. As I mentioned, when the continuum is in place, outpatient therapists will facilitate inpatient groups to discuss aftercare options. Outpatient therapists will attend an inpatient treatment team meeting to identify and meet patients who are appropriate for continuing care in outpatient. We also institute daily discharge planning groups to discuss the importance of compliance with continuing care. We know that inpatient psychiatric hospital stays are brief, and continuing care, and the longer that we can maintain an individual in a support network, in a supportive therapeutic and clinical network, the better chance at success we will have. And then again, the importance of creating the opportunity to connect with the outpatient provider to start the relationship and develop rapport is key. And finally, the process of caring contacts allows for us as clinicians in the inpatient space to encourage an individual to stay connected to their treatment provider, provide hope, and let them know that we care, that their lives matter, and it's important for them to continue in their journey towards recovery. And with that, I'll turn it back to Teresa.
Thank you, Karen. Our next presenter is Becky Stoll, the Vice President for Crisis and Disaster Management at Centerstone Health. Becky, I'll turn it over to you.
Great. Thank you, Teresa. So hello to everyone out there in the virtual world. As we've looked at this role of connecting people through transitions of care, and this focus being on from inpatient to outpatient, I've been super excited that we're focusing on that because, to be honest, this is really, I think, an aspect of mental health that's a pretty smelly sock, and we have not done near an adequate job of getting people transitioned appropriately and getting everybody in the boat rowing in the same direction. So when we look at that time period between somebody going into an inpatient psychiatric facility and an acknowledgement that they were not, quote, fixed while they were in there, and an understanding that we have to bridge this gap a little bit better is a start. But how do we do that, and what's the role of each individual entity? And I think Karen's talked about that on the inpatient side. I'm sure a lot of the 459 of you that are on the call listening to this have seen the infamous cheese slide. There's a slide in some of the Zero Suicide materials that shows Swiss cheese kind of going up this angle, and we're trying to get people to not slip through that. I really think that Swiss cheese is not kind of standing up on end. I feel like the road in mental health oftentimes is paved in Swiss cheese, and the road itself has a lot of pitfalls, and this is one of the very, very large pitfalls I think that people can fall into when they're trying to go from one level of care to the other. So this is just an area I feel super passionate about, and we just have to do better, and we have to handhold people in some ways so that we can help them either walk around the hole in the cheese, or we can somehow cover it up and allow them to walk over it, but we have to do better. So some of the things we've looked at in trying to do that, and it's kind of, upsetting and appalling that we haven't done as good a job with this in the past, but part of it is just reaching out amongst individuals that are on the outpatient side and then those on the inpatient side, and developing relationships between us. And we, I'm just looking in our system, the capacity to try to do that. In Nashville proper, there's probably 7 inpatient psych units, a mental health institute run by the state for uninsured. And then, we have a plethora of inpatient psychs that are private. But really reaching out and seeing about their willingness to share the responsibility for this movement back and forth across the bridge that gaps inpatient and outpatient care. Because, excuse me, if both parties are not willing to accept that, then, we have a problem. So maybe taking the document that was created and really talking to them about the ability to make it a new day. And, we have a new baby niece in our family. She's, I think, 3 months old now, but we spent a lot of time with her prior to her being able to hold her head. And I remember so gently trying to cradle her head, and if you passed her to somebody else, you don't want her head all flipping around, and you needed to be careful about that. I think the same thing, we have to be careful and purposeful and hold people tightly until we can pass that baton to the next person that's going to get their care, and we don't really take our hand off of the person, off the baton, until they tell us they have it. I have them. I've got it. I'm taking responsibility, and that's where I think we just have to do better. So we've negotiated in our system some MOUs around how to do that, and then looked at processes that would allow us to do this kind of work better. So that, yeah, we have policies and we have good communication, but really when it's in the real world, how can that look better? How can the inpatient unit make sure they continue to stay in contact with the person during that kind of gap before they can get into outpatient care? But then how is outpatient care filling the gap on the other direction before the person's even graced our doors? And making, a lot of that starts off with just making sure people have appointments that are at times they can come. I've jokingly, not really jokingly, but jokingly said, we often would have an inpatient psych social worker call our facilities and, they need 10 appointments. And so we would give them 10 appointments, and then they would go back on the unit and play Oprah. You get an appointment and you get everybody gets an appointment, but nobody really ever worked with the person who was receiving that appointment to see if it was a time and date conducive to their life. Maybe they've been off work while they've been in the hospital, and 10 o'clock on a Tuesday is not going to work. So, it just starts with even simple things like making sure that the appointments are specific to that person's life, and then trying to make sure they understand where the appointment is and how to get there, and is there any obstacles that are going to prevent them from coming. On our side, on the outpatient side, shooting pie in the sky, you really do try to meet the patient and their family at some point. Ideally you do that while they're still inpatient. I think in community mental health, that is much more challenging because the clinicians are, kind of turning and burning and seeing patients all day, especially in a fee-for-service environment. But if you can't have the clinician attend a treatment team on the unit or do a Zoom call and meet the person, what can you do? Is it using peer support specialists who can go into the facility and bridge that gap? Just to say, hey, you're going to see Teresa when you come in for services, and she's good people, and you're really going to like her, and things like that. Just how, if you can't have, so you have the clinician do it, what are other ways to get that piece of it taken care of? in our system, we're using hospital liaisons in that role so that we have a liaison assigned to all the inpatient units. And so they're kind of working within the facility to make sure that any patients that are being sent our way, that we're bridging that gap and making sure people get transferred over appropriately. And then on our side, on the outpatient side, we have to make sure that this is a population that really takes precedent and priority. So we're going to try to get them in sooner than someone who's, coming in for a non-hospital discharge appointment. And then we're trying to make sure on our side that the people that they're seeing for service do have training in specific suicide care so that they can treat this person's suicidality head on and not just treat other issues going on and hope that, the suicide kind of goes away on its own. And so we're trying to make sure we do those pieces not only with the person, but with any support that they have, whether that's family or friends, that we can make sure and kind of circle the wagons, pull the tribe in during this fragile time of coming out of an inpatient psych facility due to some issue around suicide. And then so when you circle those wagons, you hopefully can go out a little bit deep. Hopefully the bench can be family members, friends. I mean, you can see on this slide, do we have ways to do peer support? If it's kids, are there people in the schools that we can pull into the tribe? Other adults, if it's kids, that we might be able to, coaches or whatever, to be able to circle those wagons and pull in as many folks as we can to provide that support during this time of transition. And then we want to make sure we go back and close the loop and really tell the inpatient unit, you can take your hand off of the baton because I have it firmly in my hand and I'm going to go run towards the line, so that they know that this is a patient who has successfully been transitioned into the next level of care that's appropriate for them, and it's time for them to hands off. So it's really this shared responsibility of patients during this just crucial time period, and each of us understanding our roles and living up to our roles and both agreeing to function in those roles. If we don't all do that, then one side of the car is going to roll on round wheels and the other side's going to roll on wheels made out of squares. It's just, we're not going to get anywhere if we do that. And it takes time and it takes effort to do that. So we found in our system of care when we looked at care transitions, and we did that in a couple of evaluations that we did on some of our enhanced follow-up efforts. First thing you want to make sure is obviously that no one dies in your system of care. And in the evaluations we did, we luckily did not have anyone die from suicide. But we also looked at people not returning to emergency departments. So they've come out of an inpatient psych, they come to us, and we are able to do this kind of high-touch follow-up. And we saw that most of them did not return to emergency departments. The recidivism rate back to an ED plummeted down to about 8%. And then we looked at, so people got engaged in care, people did not die, and people did not show back up for services that really were not what they needed at the time. So that was all great on the personal care side. But we did also look in both of those studies as to whether it saved money to the healthcare system as a whole. In the first study, we did a one-year study with Blue Cross and Blue Shield, and after we took money out for the staff that it took to do this, which was about $200,000, the net savings, as you see there, was just, over $400,000. We replicated that in another 3-year study that we did on really high-touch follow-up, and the cost savings were $2.7 million back into the healthcare system. And these were not, really high salaried, high, I mean, these were people that had some good, solid clinical skills that were taught a process of following up with people, keeping their hand on the baton, and not only did it provide just excellent care, but the cost savings were really significant enough that hopefully if we can get traction around studies like these, we can put some of that kind of funding back into the system and be able to do other really cool things. And with that, I will turn it back over to Teresa to let you all hear from our sweet friend Shelby Rowe.
Thank you, Becky. Our next presenter is Shelby Rowe, the Program Manager at the Oklahoma Department of Mental Health and Substance Abuse Services, and the 2016 Chickasaw Nation Dynamic Woman of the Year. As a public health professional, crisis intervention expert, and suicide attempt survivor, Ms. Rowe has been a leader in the suicide prevention movement at the local, state, and national level since 2007. Shelby, welcome.
Thank you. So something that I hear often, especially when I go and do trainings, is someone will always come up to me and say, well, you don't look like a typical suicide attempt survivor. And so I always ask back, I said, well, what do you think a typical suicide attempt survivor looks like? And they'll just look at me blankly, and it's like, well, exactly, that it could be any of us. Any of us can be at risk. And yes, even though I am a suicide prevention professional, I've worked in public health since 92, 93, any of us can be at risk. And at 2010, I experienced a pretty serious phase of suicidal intensity, and which resulted in a suicide attempt before I was able to get some help. So just looking over, during the time when I was at risk for suicide, as a director at the time of an agency, we had our state suicide prevention hotline, and I worked with the Department of Education in that state, and we did trainings all summer. And I started noticing, I was personally struggling, but trying to act like I wasn't, and realizing, even though I may not, quote unquote, look like a suicide attempt survivor, I had a whole lot of risk factors going on. I did have a previous suicide attempt when I was 19. I had just experienced a divorce. I had a traumatic history, early in my adult life, a period of domestic violence, and I had been diagnosed with PTSD. So I had a lot of underlying risk factors. So don't let appearances deceive you. Any of us can be a suicide attempt survivor. So in 2010, as I mentioned, I went through a period of pretty intense suicide ideation and was really struggling. My PTSD, I was just stuck in this loop and really struggling on a daily basis. And it culminated in September, and I sat and was like, okay, Shelby, you are not okay. If you were a caller to the hotline, we would recommend you go to the hospital, so you need to go to the hospital now. And so I contacted a hospital. I'm sure that they laughed. I didn't request my chart, but I'm sure they laughed at me because I literally filled out my imminent risk form, and my assessment to get is here you go. You can look on the form. This is where I scored. I need to be hospitalized. So they admitted me to the hospital, and I stayed there for 7 days. I got to meet with my clinical team every day when I was there. They asked me to do things, and so I tried on the surface to be a model patient because I wanted to live. I think often when we look at individuals at risk, such as me as professionals, we're thinking, oh, well, they're trying to be sneaky or they're trying to pretend they're okay. In our society, a big thing is fake it till you make it. And even those of us at acute risk, I know from personal, you're faking it because you don't want to be at risk. You really want to be okay. And I really wanted to be okay. I did anything my therapist asked me to do. I read all of the articles. I went to the groups. And when I left, I had a follow-up appointment scheduled. But at that follow-up appointment, during my discharge, I will say we spent a lot more time talking about my payment plan than about my safety plan. They called me 48 hours later, mainly just checking to make sure I got my prescriptions filled and everything. What I really needed was, when my family came to visit, and I was fortunate enough that I did have some family members that came to visit me. I had a friend who came and picked me up at the hospital. I needed a meeting with them where they went over, what this recovery process was going to look like. I also needed some ongoing assessments, and I think it was, back in 2010, it was before zero suicide, it was before all of that, that we, on those, I don't remember anyone ever assessing my risk again. So that kind of fell through. Safety planning, other than, hey, are you okay? Will you let us know? But not really safety planning like with the Stanley Brown, where you have a plan for being okay. Because of course I told them I was going to be fine, because I really wanted to be fine. And if sheer willpower alone can reduce risk, I would have been fine. What I needed, that I didn't, was treatment specific for my PTSD, because we were treating the symptoms. In my first meeting with the psychiatrist, their inpatient, he asked me if I'd ever been diagnosed with a mental health condition, and I told him yes, I had been diagnosed with PTSD when I was 19 years old. And he said, well, why do you have PTSD? Again, that's not good bedside manner. I'm sure all of you recognize that, but kind of off-putting. And so I, rolled off the easiest trauma for me to talk about, which I said, my first husband was killed in an accidental shooting when I was 19. And he said, well, did you watch him get killed? And I said, well, no, I didn't. He said, well, then you probably don't have PTSD. They misdiagnose that all the time. And so that, kind of dismissing. So when I met with my psychologist, I didn't even tell him that I had PTSD. Even with all my training, I thought, well, maybe the psychiatrist knows better. Maybe I don't have PTSD. Maybe I'm just broken. And that just added another level of helplessness. And so for the remaining 7 days, one, they didn't ask, but two, I didn't self-disclose because I thought, maybe I didn't. But had I had that PTSD-specific treatment, we could have gotten to the root of my crisis instead of just treating the symptoms, which kind of works like the whack-a-mole game. So I got out of the hospital. I had this big hospital bill, and it was as if, my friends and family and myself, we thought a magic wand had been waved, and I was going to magically be better. 7 days in the hospital, and I didn't want to be suicidal anymore. And so my friends and stuff would say, like, well, you're not going to do that again, are you? I was like, well, no, I don't want to do that again. And I was working so hard to show my family and friends that I was better. I think within, 24 hours of getting out of the hospital, I joined a gym. I bought an exercise video. I bought a yoga video. I bought healthy food for my house. And I was on a mission to convince everyone I was fine. But I still really hated myself. I felt so bad that the money that I had for, entertainment and doing things with my sons, taking them to the movies, taking them to dinner, that money was now going to pay my hospital bill. And I had a workplace. I had my board of directors. Again, I was working at a crisis center, but I was working with them and keeping them informed of my treatment plan. And I was so fortunate that we were treating it, my board of directors and I were treating it as if I had been hospitalized for having a heart attack or had been in a diabetic coma. Whereas as long as I was working on my treatment plan and doing what was prescribed for me to do, that I could stay in my position and I didn't have to go on leave. So I was working with them, but it was really stressful because honestly I wasn't being a very good executive director. Things were falling through the cracks on the paperwork, My board was very understanding. My staff, who was used to me being their fearless leader, they didn't know what to do with a broken Shelby, and I didn't know what to do with a broken Shelby. So there was a lot of workplace stress. And in my head, I was like, I can't do this anymore. This level of perfectionism of I was going to magically be better when I got out of the hospital, it didn't happen. I wasn't magically better, and I was too embarrassed to tell my friends that I wasn't better. And more importantly, I wasn't telling my therapist. I was just super disappointed in myself and experiencing a lot of despair because I wanted to be better. I did, the night before Thanksgiving in 2010, I made an attempt on my life. I knew, like, I can't live like this anymore, and made an attempt. Fortunately, I woke up. 2.5 days later, I woke up, and after some good conversations with friends and family, I knew I wanted to live. I knew I could live, but I needed a roadmap to make that happen. And for me, the first step, for to say, is a joke, but I really think it's a good rule for life. The key to happiness, especially for perfectionists like myself, the key to happiness is lowered expectation. And I had to stop expecting perfection from myself. I had a friend at the time who was diagnosed with diabetes, and she was making lots of lifestyle changes, changing the foods that she ate and her exercise because she didn't want her diabetes to kill her. And I recognized and was taking a walk. This is a view from my barn. The first thing I did for self-care is I bought a farm. I bought a rundown farm because I could maintain rundown, but I needed a prettier place to live and I needed a place to heal. And so this was the view out of my barn door because I needed to be in a healthy, healing environment. But I started recognizing that where diabetes, for my friend, that was her life-threatening health condition. For me, it was PTSD. And I knew as a public health professional and suicide prevention professional that I now had 2 suicide attempts, and I was at higher risk. And so if I was going to survive this, I needed to make some changes. And so I had those conversations with my friends and family. One of my really good friends, my attempt was super traumatic for her. And I wish, sadly, she was the person who picked me up at the hospital. And I wish that someone would have told her and me that within the first week I would be 300 times more likely, within the first month, 200 times more likely. Because when I did make my attempt within 8 weeks of being discharged, and I called her and told her, she said, I can't do this with you anymore. I'm sick of this. I'm sick of you. I can't talk to you anymore. And she saw my still being at risk as kind of a betrayal of our friendship. It took us time to get through that, and we did, and we're still friends today. But she took it real personally. And I think that's because we had way too high of expectations of what my recovery was going to look like. So I really think, at that point of discharge, we as mental health providers, as inpatient units, even as public health providers, of setting good, realistic expectations at that point of discharge. If we sit and collaboratively create a safety plan, like the Stanley Brown safety plan, and if you do it within the My3 app, it instantly puts it into a PDF and gives you the option to email it. So even if the friends and family can't be there at the point of discharge, you can make sure that that patient has shared their safety plan with those people in their life that they trust the most. But having that collaborative safety plan that doesn't just say, I promise to be okay, but is that roadmap of, here's how I'm going to be okay, and here's when I need to know to activate my plan. Because that, the positive thinking and looking on the bright side can really create a situation where that person who's at elevated risk and their friends and family really underestimate the severity of what's happening, and we ignore those symptoms until it's too late. And then being able to share that safety plan immediately at the point of discharge with the outpatient provider. If I could have gone to that outpatient provider with my safety plan and that could have been discussed at every visit along with reassessing my risk, I think that things might have been different. I think we could have had an opportunity to prevent that suicide attempt. And I think that is the end of my slides, but we're open for questions and comments. So I thank you all for listening. And if there's anything else, I could talk all day, as the other presenters know. But I want to be mindful and give you guys plenty of time for questions. Teresa, I'm going to turn it back over to you.
Thank you, Shelby. And this is a time when we can answer your questions. A number of you have been posting them, and so we will be reading them and having our panel members answer them. So let's get started. One moment. All right. So one of the questions that came up very early on during Dr. McKeon's presentation was, do the statistics from the slides on deaths after inpatient apply to youth also?
Yes, thank you for that question. I'm not aware of a study that focused specifically on youth in terms of deaths by suicide. But one thing that's important to be aware of is that youth and young adults have significantly elevated rates of suicide attempts that are significantly greater than later in life. So the ratio of attempts to deaths is much greater. There are many more attempts among younger people compared to deaths than later in life. So I think that for youth, this is particularly important. And although it was only one component of our Garrett-Lee-Smith evaluation, we've made a requirement in our Garrett-Lee-Smith Youth Suicide Prevention Grants to provide this kind of care transitions for those aged 10 to 24 who are for those aged 10 to 24 who are being discharged from inpatient units or emergency rooms. And we found with the Garrett-Lee-Smith grants that counties implementing those activities had lower rates of youth suicide and youth suicide attempts than matched counties. Now, the Garrett-Lee-Smith grants did have a broader focus. It did have the requirement around care transitions, but there was also work with schools. There was also lots of gatekeeper training in the community. So we don't have a way of apportioning out how much of that was due to the focus on care transitions. But when you look at the kind of population as a whole, you've got really at least 4 major studies that have results showing the importance of this area in terms of effectiveness. The Motto Caring Letters study, which was strictly inpatient discharges. The WHO study from 6 or 8 different countries, that was people seen by suicide attempts being discharged from emergency rooms. And then the other areas focusing on emergency rooms was the ED Safe study and the Safe Vet studies, both of which found reduced suicide attempts using combinations of care transitions and collaborative safety planning. So that's, I wouldn't say that there is a single, study focusing only on youth that has that evidence of effectiveness, at least that I'm aware of. But I think we can really make the inference that it should apply as well. And for that reason, SAMHSA makes it a requirement in all of our youth grants.
Thank you, Dr. McKeon. Another question came in. When are the appropriate times to conduct caring contacts? Karen or Richard, could you answer that?
From our perspective,
I would say, okay,
go ahead, Richard.
so I'll be quick. I would say the sooner the better. The data is clear. I mean, ideally, I think a telephone contact within 24 to 48 hours after discharge, because we know that first day is the single day that has the highest rate around suicide. So a quick phone call and then trying to get the person into care, certainly within the first week. I think that's what a model program would do. Would get the call right away, and then, within several days after that, getting the person into care.
And I would agree. Thank you, Richard. I think that the sooner the better as well. And this is an opportunity for me to clarify one of my comments. This is Karen from my presentation. Is the idea of an outpatient appointment being with a psychotherapist, social worker, psychologist, LPC, whatever your designation is, and that my clarification around the medications and the prescriptions, it's not always as easy to find a psychiatric appointment with a psychiatrist or someone who can prescribe meds within that 7-day time frame. While that's ideal and that's the goal, we want to make sure that our patients get to an outpatient therapist during that first 7 days. So I recognize the critical part of that. And then the linkage we can do the linkage in 2 ways and check with that therapist to make sure that patient arrived. So you have the one component of doing the caring contact as we described and as Richard clarified, and then the point of being in touch with, as illustrated here, for example, a member of Becky's team, to make sure that the patient arrived at that very first appointment.
Thanks, Karen. So just to clarify, that first appointment right after discharge is really with someone who's a psychotherapist, and also trying to get a medication appointment for them, but really focusing on getting them that other mental health therapist appointment as soon as possible after discharge. Is that correct?
Yeah, if we can, yes, that is the goal, right? I mean, certainly the goal would be a psychiatrist appointment and a psychotherapist appointment in the same week. But when that doesn't happen, that's how we manage the medication issues that even Shelby raised in her, in her presentation. I hope that clarifies the question that was raised.
Thank you.
And if I could just add one thing, because there actually is one study on adolescence and this post-discharge issue. It's Psychiatric Services 2019, Rengasamy and Sparks. It's called Reduction of Post-Discharge Suicidal Behavior Among Adolescents Through a Telephone-Based Intervention. So that's one study that could be looked at.
Thank you, Richard. All right, I had a question from Andrea Hepburn who was asking about the app. Could you describe it a little more, Shelby, exactly where to find it and what the name of it is, please?
Sure, the app, and there's a couple different apps, so someone else may want to mention some of the others. My favorite is called My3 app, MY, the number 3, APP. It's available anywhere that you get phone apps, either at the Google Play Store, at iTunes, wherever you get apps, it's free. And it has a safety plan, and it has where you can, for your 3 personal contacts, you can connect it to their link, and so their smiling faces are right there when you open up the app, and it can link you directly to the National Suicide Prevention Lifeline. But the embedded safety plan in it is really cool. So you go through, you fill out the questions, and it puts it into the PDF, and then it gives you the chance, you can click on a button and you can email that safety plan to anyone. And so that it's free You know, free is always my favorite, and it's just a good way to have that conversation with friends and family. Or if you make a change to your safety plan, it's a great way to send that updated plan to your treatment team. There's some other plans that also have that, other phone apps. Richard, Karen, Becky, do any of you guys want to give a shameless plug for another one of the safety plan phone apps?
This is Becky. I mean, I can tell you what we use in some of our enhanced follow-up, well, actually, I think now in all of our enhanced follow-up programs. It's not really so much just a safety planning app, but it's really a tool that we use. It's called Life Tiles, and you can get it on, you know, all the usual suspects. It's one that providers can use. There's a cost to it, but to be honest, it wasn't really that expensive. And we developed that with a company a few years back for the National Strategy grant that we had. And it really is just tiles that provide different things. The first tile allows you to get help very quickly. It's got some crisis lines loaded into it. It's got one app that's got resources, so it's got, you know, Twitter feeds and books and all these kind of recommendations, but it also has two that really have, I think, a lot of meat on the bones. And it's got mood trackers and sleep logs and medication compliance logs and things like that that the user can select on which pieces of this they would like, and then when they decide what times a day they want some of these notifications to come to them, then those push out. And so you might want to track your sleep, and you have a little thing you have to slide, like it was great sleep or it stunk, and how many hours you slept and things like this. A lot of sliding or just little radio buttons you click. And the cool thing about it is it will dump back in, all of that data about that person dumps back into a repository for that person. So you can track sleep over time and mood over time and med compliance. It's got some PHQ functionality and things like that. So it is really on the provider side one that we've been using for quite a while, just to have some good interaction with folks and also give them some things that they, you know, decide that they would like to have as part of their care.
Thank you, Becky. All right, so there's some questions about which safety plan should people use and how can they ensure that we get them transferred back and forth inpatient to outpatient and involving the appropriate people, family members, or other supports. Karen, Becky, Richard, who would like to take that one? Shelby?
Well, I can take
this
this.
is Becky. Go ahead, Becky.
None of us were going to talk, and then all of us were going to talk. I think you have to make it a living. I was just saying this to somebody on Friday. It has to be a living, breathing document. And so to see it as kind of, you know, that it's just this flat piece of paper, I don't think is helpful. So I think it has to be something that's modifiable, that is transporting kind of, even if it's virtually back and forth between, you know, the person should have a copy of it, but there also should be on both sides of the fence, you know, the inpatient and outpatient, we should all have access to it and be updating and modifying it and be able to see kind of the evolution of what that looks like. Because maybe I put, you know, a spouse on there as a support person today, but in a week's time, you know, you've separated from that person and you're going to get a divorce, and that's really not who you no longer. So to me, just the key, besides this kind of thread that runs with the patient to in and out, is we have to make sure we're viewing it as a breathable document. And then I'll let everybody else chime in.
We certainly do that, Becky. We start with understanding what the safety plan is in the hospital, which is sort of an interesting place to start, right? The individual should be safe in the hospital. But what do we think about safety planning together? And we include the family and the broadest definition of family. So who does the individual want to be involved in this? And we identify if that person says, I don't want anybody involved, then that's a red flag for us. It's a risk that says we need to pay attention to what clinical issues are there that would prevent that from happening, and continue to encourage the individual to have someone with them. And then it changes through the course of the care, right? So as coping strategies are learned and as other mechanisms are learned throughout the hospital stay, then what leaves with the patient and the family, preferably with a signature with everyone acknowledging what are the My3 app is a great idea, right? Those ideas. And that same document goes with the patient. It is a copy with the person who's with them, if that we're lucky enough to have that happen. And then also at that same time submitted to the next provider of care. So it does evolve certainly in the time of the hospitalization, and then it evolves during the ongoing care as well.
Thank you. I believe you brought up an important part of the building connections, and that is the family or community supporters that people call family. How do you get them involved? At what point do you start exploring that, and how do you have those conversations that brings them into the understanding of that care? Start with Shelby. What would you recommend? And then we'll go to Becky and Karen.
So yeah, I think, and I'm glad that you went to me first, because I was just, well, as you were making that question, I was taking myself off of mute to respond. I think that starts at the very beginning of inpatient when, at least for my facility, I think others, where I put people on my list of people that could visit me. You have a contact list, an approved contact list when you're inpatient, so that's a great place to start. For that mental health professional inpatient, as you're looking at rotating outpatient, hey, I see you've got these 2 people on your contact list. As you're leaving, can we invite them either to an in-person or on phone or Zoom discharge meeting so they can continue to support your recovery on the way out? And I think some of it with providers are thinking, what would you do? For some reason with mental health, we treat it like it's this big, shameful secret. But if they were in the hospital in a life-threatening crisis with cancer or diabetes, we wouldn't think twice about encouraging them, who are your friends? Who are your family? I know in my family I had once, my stepdad was in the hospital and he went unconscious, and they took out his phone and saw that there was one titled Mom and reached straight out, to family because they knew someone should be up there with him, once they put him in ICU. So as care providers, of knowing that these people that we're treating, they do have people that love them, and helping them explore that. One of my friends, Pamela Endofhorn, said that one question that she's used when someone says, I don't have anyone, there's no one to say, who would you call if you had a flat tire, you're stuck on the side of the road at 1 o'clock in the morning, 2 o'clock in the morning, who would you call? And start with that person and see. But I would say start working on who are those family and friend contacts, while they're inpatient. Or when you're outpatient, start asking them and helping them to explore, because it may be that they don't have anyone that close, but it also may be that they're being self-dismissive and that they don't want to bother the people that are close. And you, as that care provider, can help them to feel more comfortable and guide them through that process of bringing in people into their safety plan to be supportive.
Thanks, Shelby. Becky or Karen, anything else to add?
Certainly, I would suggest also, as Shelby said, part of the gathering of the information that's needed, right, to conduct a full assessment and determine together, collaboratively, between the patient and their loved ones, what's required and what their expectations are, quite frankly, for the treatment course, whether it's inpatient or outpatient, starts right at admission, and that partnership in recovery is critical. So we start right at admission, and it continues all the way through the discharge and transition process.
This is Becky. I would say from the outpatient perspective, to be honest, I don't know that it's brain surgery. I don't think we ask. And I think we get very comfortable with just working with the person that's sitting right in front of us. And it's my personal perception, and having gotten to provide, a lot of zero suicide academies and things like that across the country and interact with just providers really all over the U.S., I don't know that we're taking the time to do this piece and to really be purposeful about going beyond just anybody you want to release for and kind of haphazardly signing a release, but really having conversation about circling the wagons and who could be of support for you right now, and brainstorming that, getting releases, and actually calling those folks, like during safety planning and things like that. So I don't feel like it's anything newfangled that we've got to come up with. I think it's just good common care that just really is not being done as much as it should be being done.
Thank you, Becky. And I wonder about those people in the community who might be willing to offer additional support, who aren't maybe family or friends, maybe like their chaplain or their faith community. What are your thoughts about including kind of that extended community support?
This is Shelby. I think that is a great idea of, who are those people that they connect with. So if it's not an immediate, maybe it is. If they're military affiliated, maybe it's the chaplain. Maybe it's someone they go to Sunday school with. I live in the South, so most people have people. It may be someone at their Rotary Club that they sit next to. Who are those people that they interact with? And then you can also, this is a great time to utilize peer support specialists. If you don't have those, at your facility, to get peer support specialists, to link them up depending on their other mental health conditions. Maybe start a suicide attempt survivor support group. Dee Dee Hirsch has a great model, and you may be able to start one of those groups that they can go to after they discharge. You may refer them on to NAMI and get them connected with peer recovery support folks there. But yeah, if they can't think of someone, help them explore those options of who else in their world, and it may be their primary care provider that they want to know, because that may be who's been prescribing their sleep aid medication, their antidepressants for the last decade. And so making sure that their primary care provider is part of that safety plan may be a good option. But I would just help explore. It may be cultural leaders, it may be community leaders, but we're social beings, and sometimes we just need to be reminded of who is in our social circle, because when you're in that crisis, tunnel vision sets in. So helping them explore who else is in that safety net that may be willing and able to be there for them.
Thank you, Shelby. We are coming up at the end of our webinar, and we want to leave a few minutes. I want to thank all of our presenters for their insight and for their willingness to take questions on the fly. It's been a robust discussion. If I didn't answer your question live, we will be making sure that all of these questions are answered, and you'll be getting those at the end. For more information about the best practices in care transitions for individuals with suicide risk Inpatient to outpatient care, you can see the website here, suicidecaretransitions.org. On that site, you will find tools. There is the report. You're going to find a video, and there's also kind of an executive summary 2-page handout that you can access for your use. Here's the references that we talked about today. There's a few more that came up during our questions and comments, and we'll be adding to that. And then finally, thank you so much for attending today, and connect with us at the Action Alliance. Thank you, everyone.